Good morning, everyone. And we just listened to Dr. Ziger about the medical aspects of dealing with the kidney transplantation. I'll be talking about the surgical aspects. So, as surgeons, what challenges we have is selecting the site for the second, third, or subsequent transplants. All these patients have used up vessels because of prolonged dialysis. There is calciphylaxis in the vessels, and the vessels are not as good. And that additionally leads to the vasculopathy and a complex vascular anastomosis sometimes. So when we look at the patient, we look at the vascular suitability, unsuitability, the abdominal scarring, and the urinary bladder issues. So when we talk about the looking at the arterial issues, the most important is the clinical examination of the patient. Look at the patient as a whole. Sometimes they will have blackening of their lower limbs. That's where that's a red flag. You have to see for pulsations of dorsalis pedis and tibialis posterior. Additionally, you can investigate further, do a Doppler study, and the most important for me is to do a plain CT scan at least. And if that CT scan shows significant calcification, maybe I'll take a call on doing a CT angiography. So this is an index case where if you see this pointer is not working. So if you see this is a transplant which was done elsewhere and referred to. Leave it, I can manage. So referred to us for second transplant. External iliac is not there, and this is the internal iliac. And what happened to this patient? They had to do a graft nephrectomy in emergency, and that led to the uh, absence of pulsations on the right side, and that's when the vascular surgeons intervened and they did a femoral bypass. This one, the transverse vessel which you see. This patient came to us after maybe around a year or so, and this is the vascular anatomy which we had. And the decision was to go for left iliac or to put the kidney higher up in the orthotopic position. So we finally decided, we had a multidisciplinary meeting with the nephrologist and us, and we decided to put the kidney in the common iliac. And this is how it is actually. The left iliac fossa transplant is second transplant, and you can see the femoral grafter. This is superficial. You have to be very careful in making bed, and you should take the best of the persons to make the bed, and just not leave it to the resident to make the bed. This is important actually. The second thing is about handling the vessels. So an arteriotomy is made not with a punch but with a blade here, which is more controlled. And the third important thing was, once the arterial anastomosis was over, I put a bulldog clamp on the renal artery and removed the clamps on the external iliac. So that hardly this 7 minutes was the clamp time for the arterial anastomosis. And see, this is the picture. This is the first transplant, midline incision for the fem graft, and then this is the incision. So to be honest, this patient had a creatinine of 0.6 on day 4, and after that the urine output started dropping. The Doppler was normal. The nephrologist felt it is catheter-related issues. We removed the catheter on day 5. Urine output was 0. So they did a biopsy, and it came as ABMR, and that's when plasma exchange and rituximab was started. And I think today is 18th day morning. I got a call. The kidney opened up, and he started producing urine, but he had a large collection. We had to explore remove all the clots. There was no active bleeding. At the site of biopsy, that was the place where it has bled. I had the images, but I couldn't put it here. And this is after the re-exploration. The creatinine improved, and today morning the creatinine is 1.3. That's what the resident called me and told. So as of now, things are on the patient side, but this case shows all the intricacies of the surgical aspects and the medical aspects too. So when you come to the venous issues, we have to look for previous history of access to the vein for dialysis, prolonged dialysis through the femoral vessels. And if the catheter is there for a very, very long time, then there is a possibility that venous thrombosis can be there. A good Doppler radiologist can show the things, and the most important thing is to go to the radiology suite and see the vein yourself, and just not rely on the radiologist reporting of the things. If I have to do a redo transplant, I'll go myself, see the vein, make it clear where the things are, see the artery where the things are, how much calcified and things are, and then only I'll proceed. And if there is doubt, you can the angiography is to be done. The third important thing for the surgeon is to look at the bladder. They, means if you are doing the second transplant, it's relatively okay. But if it is the third transplant, then probably both the sides are used up in the bladder, anterolateral walls, and that area is stuck. So you have to be careful there. So better to do a cystogram in all these cases. That gives an idea about the bladder capacity and reflux, if at all it is present. So when we talk about the second transplant, I have discussed the opposite iliac fossa is to be used. There is no problem as such. Only thing, the iliac vein, the left extra iliac vein, is slightly deeper there, and the division of the intra iliac vein is little distal. So yeah, most of the times you have to tie the intra iliac vein to superficialize the extra iliac vein. And sometimes if a new person is doing, probably how to means do the anastomosis, because it's reverse of what you have been doing. So a novice person can have issues initially because of orientation of taking sutures. So better to take a senior person along if you are doing the first case of your career. So when about the third transplant, now this is the situation where both the iliac fossa are used. Now what the options are? Unfortunately, I don't have the image. My computer previous one has got corrupted. I've done two cases like this, and here I went ahead and did the graft nephrectomy on the right side, and could control the extra iliac vessel distally, just loop it. We can't dissect out complete extra iliac, that's not possible. Go cranially, go proximally, dissect out the common iliac vessels, dissect out the distal aorta and the IVC, and that's where you will find a place to put the graft. So this is what I just discussed. Then is the other option is an orthotopic transplant. So here we have to give a flank incision. The important thing before doing orthotopic is to assess for the left side kidney in the recipient. So you have to do an angiography to see what is the status of the renal artery on the left side in the recipient, and what is the status of the vein. Most of these kidneys are shrunken, the vessel size is small. So if there are multiple arteries on the left side, in that situation better to use the splenic artery and for the arterial anastomosis. And the veins are usually okay. Uh, the third important thing about orthotopic is not to dissect the recipient ureter too much. You be near the pelvis of the recipient system, and don't dissect the ureter too much, because the vascular supply is from the of the ureter is the segmental supply, and you want to preserve that. So these are the only things. Otherwise, it's not something very demanding. It can be done. The only problem is ki when you look at the calcification of the things, many times the splenic artery is also calcified badly. So this is where means the decision has to be taken where to go for orthotopic. And at the end of the day, we all are humans. We can't give results everywhere, and sometimes we have to raise our hands and tell that's the end of it. Let's not do any further surgeries in you. And I think that message should be very clear to us. I think this I can skip. So if you look at the outcomes of the surgeries in redo transplant, it's good actually, and we should give the options to the patients. So that's a team I work with, and thank you so much for your patient hearing.